We are so excited to have Dr. Mark Houston share his expertise today as we highlight Module 16B, Clinical Revolution in Cardiovascular Health and Disease. This module is part of the cardiovascular certification available through the Metabolic Medical Institute and will be presented live on January 26th through the 28th in beautiful South Florida. Dr. Mark Houston is Associate Clinical Professor of Medicine at Vanderbilt University School of Medicine, Clinical Instructor in the Department of Physical Therapy and Healthcare Sciences at George Washington University, Director of the Hypertension Institute and Vascular Biology, and Medical Director of the Division of Human Nutrition at St. Thomas Hospital in Nashville, Tennessee. Dr. Houston was selected as one of the top physicians in hypertension in the U.S. in 2008 through 2014 by the Consumer Research Council and by USA Today as one of the most influential doctors in the U.S. in both hypertension and hyperlipidemia twice in 2009 and 2010. He was selected as the Patient's Choice Award in 2010 through 2012 by the Consumer Reports USA. He is triple boarded certified by the American Board of Internal Medicine and the American Society of Hypertension and the American Board of Anti-Aging and Regenerative Medicine. He holds 2 Masters of Science degrees in Human Nutrition and another in Metabolic and Nutritional Medicine. Dr. Houston has presented over 10,000 lectures nationally and internationally and published over 250 medical articles, scientific abstracts, and peer-reviewed medical journals, books, and book chapters. He is an author, teacher, clinician, and researcher. Due to the very large audience this evening, please use your chat option if you do have any questions. Without further ado, Dr. Houston, I will turn the webinar over to you.
Thank you, Lindsay, and thank all of you for joining me with your precious time. We're going to try to do some really succinct presentations in about 30 minutes. So what I'm going to start with is just a real brief overview of what Module 16B will encompass, topics and a few of the speakers. Then I want to present a case that will represent a lot of the things we're going to do in Module 16B, and then we'll open up for question and answer. So 16B is a module that I helped develop with MMI, and we've been doing this one now for almost 4 years. 16B is conceptually advanced lipidology, so we're to be doing dyslipidemia for 8 hours on day 1. And then on day 2, we go into cardiovascular disease, particularly looking at coronary heart disease, how to prevent and treat congestive heart failure, and a little bit about arrhythmias. We have 3 speakers. I'll be doing the lipid talk and some of the heart failure issues and coronary heart disease. Dr. Sergio Fazio from Portland at the Oregon University of Health Sciences will be discussing drug therapy and dyslipidemia, and Dr. Joel Kahn at Wayne State University in Detroit will be discussing some specific issues in cardiac arrhythmias and also cardiovascular disease. So I hope you can attend. We will be having this in Boca Raton in January, so the weather should be beautiful. We typically like to have relatively small groups of about 50 to 60 people, so we can really have time for a lot of case discussions and interaction with the faculty. And I think you'll find this very up-to-date, very scientific, with the ability to really meet all the professors and get all your questions answered, but also learn up-to-date information, because this module has been totally redeveloped with probably over 50% of material brand new from the last time it was presented a year ago, with some great case presentations and clinical application. So Lindsay, if you could bring up our first case, I'd like to go through this and have people sort of think about what they're presenting, and then we'll go to each slide and let you sort of pretend like you're discussing it among yourselves and think about what you would do, and then we'll go through the answers. But this is a case that I actually had in my practice several years ago. It's a 38-year-old black male who'd come in just for a routine physical exam. And he said he had a very strong family history of coronary heart disease and myocardial infarction in both his parents. His father died before 50 with an MI, and his mother had died in her mid-50s of a myocardial infarction. He says he's in great health, doesn't have any medical problems at all that he knows about. He's normal weight, he doesn't smoke, follows a very good diet and exercise program. And his history and physical are entirely normal. And he brings in some labs from another physician, which has included a routine lipid profile, which I reviewed. And I looked at it and said, well, this looks pretty good, but you know, you've got this bad family history. So why don't we do an expanded lipid profile and just be sure that nothing there is of concern. So Lindsay, if you go to the second slide. Now, what you're going to see here is the old Atherotech or VAP advanced lipid profile. This was one of the first labs to start doing advanced lipid testing. And unfortunately, this company is now out of business, but this is one of their very first profiles they came out with. So what I want you to look at first is in the lower left-hand corner. This was his regular lipid profile that he brought in from another lab, but it was consistent with what showed up also on this advanced lipid test. Look at his total cholesterol, 124. No one would be concerned with that. LDL of 70. Well, that's as good as you get treating aggressively with statin drugs or with other natural therapies. His HDL is normal at 41, and his triglycerides are phenomenal at 70. So you look at that, you go, well, that looks like a great standard lipid profile. But what I want you to do now is look up above at the bar graphs and look first at the blue, purple area. That's his triglycerides or VLDL. And in the middle is his LDL subclasses. That's in red. And over to the right is the HDL subclasses that are in green. Now just look at that for a moment and just think about what you're seeing there, and if there's anything on that bar graph of the different subclasses that would bother you related to his lipid profile. So let's do the VLDL triglycerides first. What is the largest bar there? Well, it's the large VLDL. Those are the ones that have the highest relationship to atherosclerosis, coronary heart disease, myocardial infarction. So even though his total triglycerides are 70, it's preponderant of the worst type of VLDL he could have, which is the large one. So that's an atherogenic VLDL profile. Now you go over to the LDL subclasses, and what do you see there? Well, now you see that it's mostly small, dense, and intermediate dense LDL cholesterol, and those are the most atherogenic coronary heart disease, MIs. Those are the particles that get through, because they're very small, they transport through the endothelium, and then they go into the subendothelial layer where they deposit, and then they're modified and become atherogenic during that modification process. So that's also atherogenic, even though his total LDL is 70. Now go to the last one, which is the green. That's the HDL map. And what do you see here? Well, he's got mostly the small and intermediate HDL, which is typically not protective compared to the large HDL. So he's lost the ability for reverse cholesterol transport and a lot of the other good things that HDL does related to atherosclerosis and MI. So despite the fact that his standard lipid profile is normal, when you look below the surface, every one of his lipid analyses with the advanced testing, either particle size, and we'll show a particle number in a second, are abnormal. So that puts him at increased risk for coronary heart disease. And had you not done this advanced lipid profile, you'd have completely missed it. Now the next thing that shows up, you go to the next slide, Lindsay. Look at his LDL particle number. Now, at that time, the particle number by the VAP test was considered normal if it was under 1100. But it's turned out that number is way too high. The real number should be 700. So if we take it by today's standards, his LDL particle number is 999, which is too high. So he's got increased LDL particle number, and it's the small ones. And you can see there, it shows you the LDL particle size being pattern B, which is small. And you look at his HDL, which is intermediate, and then his VLDL is also intermediate. So all the things on that page increase risk for atherosclerosis. Okay, let's go to the next slide, because you want to ask yourself another question. Is there anything else you're missing? And it turns out, yes, there's two things. One is the Lp(a) is very high, it's 120, and normal by the VAP test is less than 30. So this is one of those hidden risk factors within the lipids that is related to increased risk for coronary heart disease and MI, and it also, we now think it's the highest lipid for risk for stent restenosis and bypass graft restenosis. And it's most physicians don't even measure Lp(a), and you won't get it on a standard lipid profile. You must do advanced lipid testing. And the Lp(a) has to be done by a good assay, and you have to know how to treat it. In addition, his high sensitivity C-reactive protein, hsCRP, is borderline high. It's 1.5. Now, it should be less than 1. So he's got very distinctly abnormal lipid profile, and he's got some vascular inflammation. So those two tests right there explain a lot of his potential risk for coronary heart disease. And we don't know what his family history was because we don't have any data on his parents, but it's very likely his parents also were dyslipidemic and may well have had this high Lp(a), because Lp(a) is genetic, and it's the most hidden of the lipid profile risk factors, and it's the most difficult to treat. So think about what we've got here and ask yourself a couple of questions. So let's look at the next one, which is your audience response questions. I want you to pick one of these and tell me what you think. So number one, this patient needs no treatment and is at low risk for cardiovascular disease. Number two, patient should be treated immediately with high-dose statin therapy. Number three, patient should be treated with appropriate non-drug treatment such as niacin and omega-3 fatty acids. Or number four, patient should be treated with a combination of fibrates and statins. Where the correct answer is number three. He should get non-drug therapy with niacin and omega-3s. So why is that? Well, you could put him on a statin, but he's already got an LDL of 70. And the problem is not the LDL level, it's what's within the LDL. And statins don't really change LDL particle number very well, and they don't increase the LDL particle size very well. And those are the driving forces in this man for coronary heart disease in addition to Lp(a). And statins do not change or lower Lp(a). So if you put a patient like this on a statin, you're really not going to change his risk for coronary heart disease. But on the other hand, a niacin will decrease LDL particle number, and it will increase LDL particle size from a B to an A. Niacin also lowers VLDL and triglycerides, and it improves HDL size and HDL function. So niacin is a superb nutritional supplement that will reverse all of the standard lipid profile changes on the advanced test as well. In addition, niacin is the nutrient or supplement of choice for Lp(a). It's about the only one that's got good data, and depending on the dose, you can get 30% reductions or more with Lp(a). There are other treatments for Lp(a), which we'll talk about in a minute. Now, what about omega-3 fatty acids? Well, those work in conjunction with niacin. Omega-3s will lower LDL particle number, increase LDL particle size, lower triglycerides and VLDL, and increase HDL functionality and HDL size. Omega-3s also may have a mild effect on Lp(a), and both niacin and omega-3s are anti-inflammatory, so they will lower his HS-CRP. So you can see those two have dramatic effects across the board in this particular patient. So let's look at the treatment that was offered on the next slide, Lindsay, and the doses of the things that were given. Then I'll explain why these doses were given and why we gave the specific nutrients. So niacin B3, he started out at a low dose, but eventually worked his way up to 1,000 milligrams twice a day. Tolerated it well, didn't have a lot of flushing, and we gave him some things to keep him from flushing, like take some aspirin, don't take it on an empty stomach, take it with food, try to avoid alcohol when you take your niacin, don't interrupt the therapy. And the other thing you can do is tell the patient to eat an apple, which has quercetin in it, or you can actually give a quercetin supplement, which blocks the flushing, which is primarily through prostaglandin D in the skin. So you can stop the flushing by doing all the things I just mentioned. Second thing I gave was N-acetylcysteine, and NAC was given primarily because it lowers Lp(a). And then the omega-3s, we talked about all the reasons for that. Now, the last three you see up there, vitamin C, buffered, lysine, and proline. That is the Linus-Pauling protocol. And what that does is it prevents the attachment of the Lp(a) to the vascular endothelium. So what you're trying to do here is two things. One is reduce the total amount of Lp(a), but whatever you can't reduce, you want to keep it from attaching to the blood vessel. And that's what the last three things do, the C, lysine, and proline. And that's the standard dose you would give for Lp(a) with the Linus-Pauling protocol. And you can see at 2 months what happened. His LDL didn't change that much. You'd expect it to, but what we've done is we've modified the advanced lipid test, improved virtually everything. The particle number's down, still not quite where I want it, but it's getting close. The LDL size has gone up, and that's now normal. HDL did not really change total, but look what happened. The big, fluffy HDL-2B went up from 16 to 24, and that's a significant increase, which has a dramatic effect on reducing its risk for heart attack. Triglycerides dropped a little bit, but again, it's not so much the triglyceride level so much as it you're dropping the big, fluffy, dense triglycerides, and that reduces risk. And his Lp(a) went from 120 down to 70. Not normal yet, but dramatically improved. So everything that we did modified his lipid profile, his risk for coronary heart disease, and these can be modified and adjusted even more, but overall that's a very good start. And I put in some reading for you, Lindsay, if you can go to the next slide. That will be very helpful in your preparation for Module 16B if you get to come, which I hope you can, but also general reading about lipids, advanced testing, how the vascular biology comes in, and our newest book that I wrote with Dr. Sinatra, which is on nutritional strategies in cardiovascular disease. So Lindsay, go to the next slide. That's just a cover of the heart disease book, which you can get off Amazon.com. And then the very last slide, Lindsay, is nutritional strategies in cardiovascular disease, which has got a multi-authored text including all the latest nutritional strategies for reducing heart disease. So why don't we've got about another 10 minutes, so we can open this up now, if you would, Lindsay, for Q&A.
Sure, fantastic. Thank you so much, Dr. Houston. If anyone has a question, certainly input that into the chat option, and we will address all of your questions. But I also wanted to highlight that we are going to be doing a very nice special for those who are on the webinar this evening. For those who register with me after the webinar, we will be offering $750 off of the tuition. So please give me a call at 561-777-6807. And if you have any questions, happy to help at Lindsay, Lindsay, at a4m.com. Okay, Dr. Houston, I do have a question for you. Besides NAC, what other strategies can help lower Lp(a)?
Well, the things I put up there are the best. There's anecdotal evidence for things like carnitine, but honestly, the ones that I listed are the only ones that have pretty good science behind them. So always go with those first. And if you don't get a response, you can try some low-dose carnitine, like 1 gram twice a day. And there's a little bit of data with coenzyme Q10, maybe 100 milligrams a day. So start with the scientific part and then add the next ones if you need to.
Dr. Houston, what labs do you recommend?
For advanced lipid testing, you've got some pretty good choices now. You've got the old Berkeley Heart Lab, which was purchased by Quest, and so that one's covered pretty well by insurance. You have SpectraCell, which has one of the best lipid testing around, and it's very inexpensive now. I think they've dropped the price down to about $100 or less. Then there's NMR technology, which used to be LipoScience, and I think they just got bought out by LabCorp. You've got Boston Heart, Vibrant Labs, and then Health Diagnostics, which is, I guess, now True Health, which is a reformulated company. So those are the ones that are out there. I've used all of them. They're all good labs. Just find the one that's best suited for your patient. Doesn't cost a lot, covered by insurance if possible, and they're all pretty easy to interpret.
Thank you. Dr. Houston, have you seen any lowering of ApoA1 and alpha-1 HDL with using red yeast rice and berberine together?
Red yeast rice and berberine are very effective for reducing LDL, LDL particle number, and apolipoprotein B. I think your question was HDL and ApoA. Actually, both of those increase HDL and ApoA, or they don't change it, but I've never seen either one of them have an adverse effect on ApoA1 or ApoA2 or HDL, even at any dose. Now, we use red yeast rice with a very high quality. The company that I use mostly is Biotics Research for red yeast rice, and they have a very high quality berberine. So if you use high quality, you tend to get very good results on expanded lipid profile with reductions in all the atherogenic particles, with actually increases in HDL particle number, and HDL size.
Thank you. Dr. Houston, is niacin a favorable aid in treatment? Isn't there a problem with adverse effects and little benefit? Can you elaborate?
There were a couple of studies, as you know, in the last 2 years that sort of bashed niacin and said we shouldn't use it or it didn't have great outcomes. And I could get into great details about those studies when we have some time, and we will in Module 16B, but just to make it simple, the AIM-HIGH study and the HPS Thrive study were the two that were purported to show that niacin didn't have good effects. But if you review the studies, they were both extremely flawed in their design and their methodology, and they're really not good studies. And plus, there's about 15 or 20 other studies, either before that trial and also after those trials, that show that niacin is not only effective in virtually every lipid you want to measure, but also reduces coronary heart disease, myocardial infarction, carotid IMT, carotid plaque, and all other types of cardiovascular disease. And the other good news is you don't have to give extremely high doses of niacin like you used to. There's new data suggesting that low doses of niacin is very effective. I'm talking about 500 milligrams, 750 milligrams, maybe once a day. And when you do the lower doses, you don't worry so much about the side effects. Obviously, you're still going to monitor all these. So some of the side effects that you know about that you want to monitor in anyone on niacin, check their blood sugar, check their homocysteine levels, monitor their liver functions, and if they have skin rash or itching or that sort of thing, you may have to stop the dose or reduce it. But the flushing part, which I talked about earlier, is fairly easy to treat. Other than that, there's really not a lot of problems at all once you use the lower doses. If you get into trouble with homocysteine, just treat the homocysteine like you normally would with methylated folate, B6, B12, and SAMI and other things. And then the blood sugar is usually not a very significant increase, even if it goes up at all. That's pretty easy to take care of just with changing their diet a bit.
Great. Dr. Houston, which gadgets do you recommend for heart rate variability measurement?
Well, we have several gadgets that we've used. One of them is the SpectraCell. It's the EndoPat heart rate variability. So EndoPat, as you know, measures endothelial dysfunction, and they have a software package now that allows you to measure heart rate variability, but also can measure augmentation index or arterial elasticity. So that's a very good test to get 3 different things. And then there's other companies that use heart rate variability. You can get standard testing, 24-hour testing. You can even get apps downloaded onto an Apple iPhone, and you can actually check it yourself with a little connector that goes into the iPhone. So look at what I would do to get a good purview of other companies. You can go on just put in heart rate variability in the Google search, and it'll pull up probably 6 or 8 different companies that offer very good HRVs. But the one that we're using is Itamar, which is the EndoPat technology.
Thank you. Dr. Houston, what is your take on the use of magnesium in patients with cardiovascular disease?
Magnesium is vital and very important for everyone with any type of cardiovascular disease, whether it's coronary heart disease, congestive heart failure, hypertension, dyslipidemia, insulin resistance, or diabetes. And you want to give enough magnesium that it increases the red cell magnesium content, because it's intracellular, and you can't determine good magnesium levels by measuring just serum magnesium. So get intracellular magnesium. And then what you give is a chelated magnesium orally, usually about 500 milligrams twice a day to get the level normal, or they have diarrhea. If they get diarrhea, you can back off on the oral form, and you can give either transdermal magnesium. There's several companies that make that, or you can have them do an Epsom salts bath at night. Put about 2 cups of Epsom salts in hot water and sit in it for 20 to 30 minutes before you go to bed. Magnesium is absorbed through the skin into the muscle, into the bloodstream. It's a very nice way of getting magnesium up without having issues of diarrhea. And the other thing you can do is give a magnesium potassium salt. The one that I use is from Biotics Research. It's called K-Mag. So K-Mag together, potassium, magnesium together. It's a salt. You put it in a smoothie. You don't even taste the salt. 1 or 2 scoops of that per day gives you lots of magnesium and potassium, which work together in reducing cardiovascular events.
Wonderful, Dr. Houston. I don't see any more questions at this time. If anyone does have a question, certainly submit it and we will address it by email. Again, I wanted to thank you so much, Dr. Houston. We do have a very special offer this evening. Please give me a call to register at 561-777-6807. Dr. Houston, do you have any final words for us this evening?
I just want to just invite all of you to come. I think this is an amazing conference we're doing and it'll allow you to really change the way you practice cardiovascular medicine. It's really geared towards primary care physicians. This is not for cardiologists so much, although we have cardiologists who attend and they learn a lot too. But it's 24 hours, 8 hours a day, and it's different because of our interaction with the faculty and our case presentations, very clinically oriented. And even if you haven't been to any of the advanced modules before, you can look at module 16A, which we just finished about a month ago. You can do that online if you want to, and then come in ready to go with 16B. And I didn't realize you had such an amazing discounted offer, but boy, that's pretty amazing, the discounts you get just for being on the webinar tonight. So hope to see you all there. I'd love to teach you something about cardiovascular disease. And thanks for being on the conference.
Thank you, everyone, for joining us, and thank you again, Dr. Houston. We'll see everyone soon. Thank you. Good night.
Good night.